If you remember, I had already started talking about fatigue in the last particular program, and that time it was kind of a straight lecture, and it talked about the difference of let's think of it this way. How I started with this idea was this. Tiredness is the most common complaint in basically all of medicine. When we see a patient, half the time they're not really sure what's going on, but then they tell you that they feel tired. So with that, we end up talking about a lot more than maybe what they ate for the day or how much sleep they had. There's a lot more involved with that. And what I had shown last time, and I have handouts from the last time I can give to the guys who weren't here last time, but what I did at that time, I showed how you can have tiredness redefined a little bit more clearly, okay, as such as fatigue or depression, things like that. That's the first thing. Once you do that, then the next step is to look at, from that patient's point of view, what symptoms they're actually having, then try to correlate it with, is it from a peripheral cause, okay, which will be something like person overexerted themselves, and they have a loss of ATP and a whole bunch of biochemical stuff, and so the loss of decreased glycogen in the muscles. This is the simplistic model, and but that's peripheral. Then there's another aspect that's central. Okay, so think about it this way: with central, we're talking about basically the mind. Okay, you could even say brain, but its mind is actually very much a part of this, and at that time, I had explained when they had a study, and they had trained athletes. Trained athletes were put together with people who had never been athletic at all, and then they had them go through these activities. What happened was that, to make a very long story short, when the I guess you would say the newbies were doing the exercises, 4 areas of the brain were stimulated, and they were very tired, very exhausted. And then after that, as time went on, they got a little bit better. But then when you made a comparison between the athletic people who've been training for a while, 3 of them did light up as being stimulated, but there was a 4th one that, even though the newbies had it really outrageously high stimulation, very little stimulation for the athletes. And the reason why is their mind had changed a little bit, and there was an attitude towards what they were doing. They were not as upset about things. So in essence, a lot of energy that was going into that area was no longer present. And then as they trained the newbies, those people, sure enough, that 4th level started decreasing also. So they were starting to show how this was occurring. As part of that whole process, that's how they got to see on a physical link between exertion and fatigue and tiredness from a mental level, and not just simply from a biochemical level. What I'm doing right now is just reiterating what we did the last time, just to have everybody caught up to snuff. This was also a handout. How do you define fatigue? And it's words that we use, but they have a way of showing more peripheral versus central. For example, on the peripheral side, tiredness, that's the all-encompassing word. Then you have somnolence, sleepiness, exhaustion, lethargy, listlessness, weaknesses, decreased loss of consciousness, brain fog. A lot of this is a mixture of brain as well as peripheral. Then you go into more obvious central is powerlessness, depression, amotivational, which means you're not interested in doing anything. Apathetic is the same word almost. Weariness, lassitude, and exhaustion. So you can see right from the get-go, we all have a different interpretation of what tiredness means. And the same person can have different interpretations based on how they feel. So to me, that's kind of important. So that basically just shows you how how broad this category is of tiredness. Okay, now today what I want to do is actually the handouts. Do you have the handouts in your thing? Okay. The first thing is going to be here. We don't even have a clicker here. Let's see here. Okay. History of symptoms. Now, the purpose today was actually to have you guys think about, not necessarily yourself, but loved ones, and what symptoms they may be having, and how would you explain this to your doctor? Oop, that's going to fall. How would you explain this to your doctor or whoever it is, okay? Because you have a healthcare worker, and you know they're always busy, and they'll ask you some simple questions, and too often the questions are yes and no, so you really can't get your story out. You want to talk to them, but they don't have time to listen to you. I see this all the time. Okay, so in here, what I'm trying to do is, basically I'm trying to get a story from the patient as to what's going on. So in the very first one here, how long have you been feeling tired? That's the first question that people often ask, and most people don't tell you the truth. What they'll say is, well, I've been feeling bad for the last 3 months or last 2 months or something like that. And then we have, do your symptoms come and go? Well, that's probably a reasonable question. How do you feel when you wake up? That's an important question. And do you sleep well, which ties in with this? From my point of view, when someone's having tiredness, the first thing to do is to separate out, is it sleepiness or is it fatigue? Okay? And yes, you can have both, all right? But that's the first thing I try to do. So I ask people, when you wake up, how do you feel? This is before medicines, before breakfast, any of that stuff. How do you feel then? Okay, because that says a lot. So let's say the person, when they wake up, they feel fine. They feel, I feel pretty good. And so when do you start feeling sick and tired? Well, at that point in time, I'm going to be trying to elicit whether their feelings of tiredness are primarily in the morning or versus in the afternoon with activity or whatever. So at that point in time, if the person does feel pretty good, the next step is to determine what their blood pressures are and also pulse about 2 hours after their medications. So what we're dealing with patients who are already on medications. Too often what happens is, I would tell you this happens every day. Every day I see this. Person comes in and they're telling me they're feeling tired, and sure enough, I get this feeling that they're okay in the morning. If they have breakfast, they're not having a problem with breakfast. Okay, but about 2 hours after they took the medications, their morning medications, that's when they start having a problem. And that's because what's going on is they're having problems with the medications. The medications are too strong for them. Now, it doesn't mean that the medicines all should be cut back, but they should be readjusted, all right? And the typical response is, well, what do you mean you don't feel so good? And they give you a very nebulous answer. They say, I feel fine, except I just want to sit down. Just let me sit down, I'll be fine. I hear this all the time. Or let me lay down, but usually it's sit down. If I sit down for about an hour, then I'll be fine. Well, what's happening during that phase is their blood pressures are dropping. So let's say you had a pressure here that was about like 120, and it'll drop to perhaps even 90 or 95 within that hour and a half after the medication's taken. And this often happens with cardiac patients, but all patients who have high blood pressure, who are on a bunch of meds, this is what happens. So if you make a simple adjustment of the medications, like taking one of the medications for the morning and switch it to nighttime, you often solve the problem, okay? So that would be someone who wakes up and they're kind of perky, but then they get tired. Now let's take point of view of the person who wakes up and they feel tired. And they're just, I said, well, do you feel like you had a good night's sleep? And they go, no, I don't feel like I have a good night's sleep at all. And then the question is, well, how good was your sleep last night? And if they're able to talk about it, then if the answer was their sleep was bad, okay, kind of a straightforward answer, then a sleep study is really required. I think it is these days. And they're easier to get now than they used to be, because now they have home sleep studies which can be ordered, and they can be all done at their own house. You don't have to go somewhere. But it's very valuable information. About 50% of all the men who are over 50 who are carrying some weight have sleep apnea. They don't know it. So that is one aspect to it. But supposing now they say, no, I don't have a problem sleeping. I'm sleeping all the time. I probably sleep maybe 8, 9, 10 hours. And then I'll say, okay, well, in that situation, is that every day? Well, sort of, yeah. I'll have a nebulous answer like that. And those patients, you have to think of depression, okay? So what happens is patients who have basically they feel poorly in the morning when they wake up, they haven't slept well, okay, then maybe they have a sleep problem, okay? But the other group that has slept well, that usually is depression. So what I'm saying here is about a 90% call. So 90% of all the people who answer the question, I feel lousy in the morning, it's one of those two things, okay? So it is relevant. And to be honest with you, a lot of people, what they do is they're getting older, because we're all getting older, so that's their answer for everything. But it's really not true. It's not because they're getting older. If they have sleep apnea, that's a big deal, okay? So let's talk about sleep apnea for 1 second here. How many people know something about sleep apnea besides the word? Okay, all right. Well, I'll just give you a quick rundown. Sleep apnea is really significant in the United States. Number one, a huge number of people, their end is right there on the roads. They basically have head-on collisions, all right? And those people with sleep apnea, they often die about 10 years before they should. And the 10 years of life that they have before then is more miserable than they should have been, okay? And the reason why is because sleep apnea it involves a loss of oxygen to the brain, and for that reason, you're not thinking straight. So you might be in your 40s and you're perfectly fine. By the time you're in your 50s and you have sleep apnea, next thing you know, you're a little scattered. It's kind of like you have some ADD or something. And you can't remember things the way you should. And everybody says, oh, I'm just getting older. But it seems like it's kind of fast moving. And naturally, when that happens, people are saying, the patient's saying to themselves, well, I don't know, do I have Alzheimer's? Or maybe I've got something like that. And he or she will never talk about it, but it's in the back of the patient's mind. Now, the family is wondering what is going on here, because their memory is fading quickly, and it's kind of scary when you see these things. So in that situation, what we have is a progressive memory loss caused by lack of oxygen to the brain while sleeping, because you're not sleeping correctly, okay? So it's all bad, except for one thing. If you are treated for it, it's reversible. So you can have a person who is really scattered and is really having problems, and they're on their sleep, they take their equipment, use it, and within 6 months, it's like they're 10 years younger. Their brain is like, it's working, it's clicking now, okay? It's very dramatic, and we see this a lot. As a cardiologist, I see a lot more than you think, because we have a lot of patients who have rhythm problems because of this, okay? In fact, patients who wake up at night on a regular basis because of a really fast heart rate, we call it PAT and SVT and these things like that, those rhythms often are seen with sleep apnea. And in fact, 43% of the people who die in bed asleep, it's sleep apnea. That's what it is. So, and it can happen to young people, like Mama Cash, she died, and that was one of the reasons why she died, so, from the 60s. So here we are just starting about one aspect already, waking up. That's a key thing. Now let's go a next step further. Supposing the person has woken up and you don't have good answers for anything so far, but they say after they had breakfast they feel tired. A lot of times we'll have patients, they'll say, hey, I wake up, I'm okay, I have breakfast, and I want to go back to bed. Well, why do you want to go back to bed? Well, I'm sleepy. Well, at that point in time, you're starting to think that there's a sugar issue and that their blood sugars are going up. Usually, it's not like they ate a huge amount of food. It's just simply that their body's not handling the sugars, the starch as well. And so for that reason, their blood sugar could go from, let's say, 100 waking up to like a 190 or 200 within just a short amount of time having some oatmeal, oatmeal and orange juice. It's a great 1-2 punch, So do you feel sleep well? We've gone through that. Another very important question is with activity. Activity is obviously important for multiple reasons. You could think of a person who has fatigability after, let's say, exercising a small amount. Well, you could be thinking cardiac. Yes, you could. But there's other things involved besides cardiac. You could easily have an anemia. You could have a low thyroid. You could have, depending upon the age of the patient, maybe some disability or some difficulty walking, and that makes them tired because they have to do a lot more effort into it. Okay? And so one of the questions is it predictable, like reproducible, that they'll be physically active and then they get tired? So that's important to know. And then the next question after that, follow-up, is if you rest, do you feel better, or is it kind of like, yeah, you're feeling bad all along and you don't really feel that much better? Okay? So patients who have anemia, they have a tendency to, the resting helps a little bit, but not that much. And patients who have more dynamic problems like cardiac and pulmonary, they will feel better. Here's a question about any change in the seasons. So let's think about wintertime in Altoona, okay? So probably by the time it's the end of January, I'd say the guesstimate is going to be about half of everybody is depressed, okay, by the end of February in Altoona. And the reason why is because you've heard of seasonal affective disorder. So we just don't have enough sun. If you think about it, now it's February, and all of a sudden the sun comes out, and everybody's more excited. They're jumping around, driving cars faster. It's just kind of crazy, And in fact, I was talking to my daughter in Seattle, and she says the same thing happens in Seattle. They just go nuts. They're just driving all over the place. So it's all of a sudden they're invigorated. And it's not a crazy thing to think about, because think of it this way. How do we actually, like in the morning when we wake up, how does the body know when it's morning? It's not because it's a clock there. I mean, cavemen didn't have clocks, right? It's the sun. I used to think it was, we had with our circadian rhythms, we had a set point, and we kind of like knew how much sleep we're supposed to have. It's not that at all. It's the sun. So the sun hits the optic nerve, and that's what tells because the optic nerve is directly connected to the brain, tells the brain, hey, it's morning. And and that's how we're reset. And patients who have shift workers disease, their work, it could be, healthcare personnel, but it could be truckers, it could be anybody who's working like 2 shifts back and forth, like 3rd shift, 1st shift, that type of thing. After a while, they get kind of goofy. They don't know what's day or night anymore. They lose it. But the remedy is actually not hard at all. You literally give them a set of lights that are like those, the ones that have the full spectrum of light as the sun would have, but not as bright. And you train them, and they get up a certain time every day, and then let's say at 9:30 in the morning, and then as time goes on, you bring it down slowly to 9:30 to 9 o'clock to 8 o'clock to 7:30, whatever time they want to wake up normally. And then once they have that, then they're finished that training period, so to speak, and then all they have to do is get up at that time later on and just have the sun hit them just at a glancing level, and it resets their circadian rhythm. Okay? So here we have, so the change of seasons is a very important question, because if we have a situation where it's dark and gloomy, or here cloudy, we have lack of sun, just like for those reasons I just mentioned, you feel depressed, okay? And that depression is not necessarily the classic, really severe depression that needs some type of medication. It just needs more sun. That's what you need. And over here, anything can help, so this is the question here is, was there anything that could help or trigger the symptoms? And so that's an important question to ask. If the person is getting tired, but it's precipitated by something specific, that's an easy thing to focus on. Here's something that's kind of interesting that it's worth taking information down, and it's included in your handouts. These are specific things that might help you as far as figuring out where the tiredness is coming from. Some of these may be obvious, but at the same time, what happens is, dying on me. It's just worthwhile by having the whole list there, and that's not a complete list, but it certainly is pretty complete. If a person comes in and has a fatiguing illness, we look at these, and then I go back to the first step to reassess what they're doing, because we're spending more time and we're letting them let things percolate in their minds a little bit, their history. So here we have travel and infections, and there we're looking at, are there any vectors of infection, like person comes from, like went to Europe or something, came back and they're sick. Of course, if you go to one aspect of illness, let's say you had fatigue, but it was also in the setting of diarrhea and things like that, it could be Montezuma's revenge, some type of different E. coli, or it could be something more like parasitic, where it could be like any type of parasites you can imagine from different countries. Immunosuppression drugs is also part of it, and that's not written up there, but Lyme disease and tick is a big one, okay? The approach to Lyme's disease is much more aggressive now than it used to be. People would say they would just go ahead with giving, just take a look at it, and this is, are you feeling fine, and nothing is done. That was like 15 years ago. Then it came to the point, well, now we'll write your script for something, usually doxycycline, and that's going to be for 7 days, which is also kind of a joke. But we now know that you really have to be aggressive with it. The epicenter for the United States for Lyme's disease is no longer like Lyme's, Massachusetts, or whatever it was, whatever state it was. It's actually very, very far away. Where is that place? In Huntington. Huntington, Pennsylvania is the epicenter for Lyme's in the United States. And so what happens here is, if you have a bite, any type of tick bite, and typically it's going to be deer, which is very small, that's a 50% chance you're infected. 50%. It used to be 1 in 20, now it's 50%. 1 in 2. And if you're infected, it might have 2 separate types of bacterium in there. The actual spirochete type from Lyme's, but then there's another type that's kind of tags along with it now. So that's a big deal. And treatment for that, for most people who are the Lyme's experts, and we're going to have a Lyme's expert in here, hopefully next month, I meant to say. So Dr. Jones is going to be here, and she'll spend more time about that. In the meantime, just be aware of, if you have a tick bite, you need it addressed seriously. They should be giving you antibiotics right then and there. And the only exception would be if you were allergic to many antibiotics. Okay, at that point in time, then we would reassess it. Sore throat. Sore throat sounds kind of silly, but it isn't at all, because you can have sore throat from various types of viral infections, but also other things like you could have EBV virus. You could have various forms of viruses that are coming from other countries. You could also have a form of lymphoid type of aggression, not necessarily aggressive, but a lymphoid process, which then can develop into a type of cancer. There's one of these non-Hodgkin lymphomas. So these are big deals. Upper posterior pharyngeal cancers are pretty common these days, and they're also brought on by various viruses. Let's see what else here. Hepatitis and hepatitis C, of course, these are, this is a major illness. Anyone who's had hepatitis C can tell you that it's really life-changing. Fortunately, they have a new medicine out that apparently is doing a good job for this, but I don't pretend to be an expert in it. I don't give out the medicine myself. That would be from the infectious disease people. Look at the next one, cold, heat intolerance, weight loss, weight gain. So there, you could obviously be thinking of maybe there's a thyroid issue. You could have, hypothyroidism versus hyper. You can get both. In other words, you could have hyperthyroidism, which would give you the weight loss, and then hypothyroidism could make you feel cold, as well as having the heat intolerance, also weight gain. So a thyroid is one section. Another aspect, another type of infection, not infection, but ailment would be inflammatory disease. All types of autoimmune problems can present this way. Joint pain also and rashes. This can be related to autoimmune, like lupus, things like that. But some of the more mundane things, like rheumatoid arthritis. So these would have inflammatory markers that would show abnormalities. And then here, this is an interesting concoction here of symptoms. Numbness, visual changes, memory problems, and loss of balance. So you can see this is a neurologic problem and visual. So this could be heavy metal, possibly could be post-traumatic issues, but mostly heavy metals would give you this loss of balance, memory problem combination. Depression and bleeding is a big deal tied in with anemia. So we have a lot of patients who have various forms of anemia, and they present with low level degree of tiredness and fatigability. And here we have any obvious things like a family history of heart problems, particularly if it's like early, premature, stomach problems, diabetes that's out of control, hypertension, and cancer. So I'm going to stop right here, and now I want to just, if you guys have questions, because I want to have more time to answer questions that you may have. I'll leave that up there for the time being. First off, any questions about what I was saying originally? The first section here about the onset of the problem, onset of feeling tired, etc. Yes.
So your seasonal issue,
Mm-hmm.
would one want to increase their vitamin D?
Yes.
And if you did,
Mm-hmm.
can you take too much vitamin D, or how do you know how much vitamin D you take?
It's a good question. It's also kind of a situation where there's still confusion. I'll give you why. The reason is because we're all taught the same thing. We're all taught A, D, E, K. These are the vitamins that are fat soluble, and for that reason, they can cause toxicities if you take too much. And it's true, period. Everything that we learned of until around 2010 was based upon D2. And in fact, if you were to get a prescription of vitamin D right now, it still would be D2. All right? However, D3 was found out after beginning of this century, and it became more obvious that D3 was the best agent to use. And not just for treatment, but also the receptor sites are more related to D3. Okay? So let's think about this. We have 1 trillion cells in our body. Every cell has a thyroid receptor. That's a lot of thyroid receptors. Turns out we also have a D3 receptor. So in essence, vitamin D3 is not a vitamin, it's a hormone. That's how big it is. It's like, whoa, this is big news. And so, I've talked to many people, and a lot of people still don't understand, or let's say they reflexively disagree because they knew all along, and I totally get it because I made the same mistake, okay? Now, we live in central Pennsylvania, right? Now, as it turns out, we don't exactly have the strongest sun in this area. We'd all agree with that, right? Okay. So, as it turns out, how many months of the year do you think we get enough sun to actually stimulate our vitamin D? And we have 12 months. So your choices are between 1 and 12. How about this group over here? What? 3. Okay, over here? 5. Somebody said 2. Over here? 6. Oh, you're very optimistic. I'm sorry. 2. 2. So July and August are the only months that we get enough sun to even stimulate. Now, half the time, it still won't be stimulated because what are we doing on our skin? We're putting something on, a blocker, right? And so we're not really getting enough D at all. Now, why is that important? I mean, who cares about bones anyway, right? It turns out, remember what I just said, vitamin D is a hormone. It affects the whole body. So here's a very interesting thing. We found out something. If you have a low vitamin D level, that increases the possibility of cancer, heart disease, arthritis, keeps going on. Even depression, but there's something similar to what's going on. These are all the chronic illnesses we're talking about. Essentially, what happens is a low vitamin D level ages you. You age quicker because your body's not compensating because it doesn't have the hormone. It's a big deal. And it's the best bang for the buck. You can go to, we can try to sell you vitamin D3 for $1 million a bottle, right? It's not necessary. Go to Walmart and spend $7 and that's all you need. It's that cheap and it'll do the same job. And you'll have people saying, oh, the liquid stuff is better and you got this and this. Yes, but believe it or not, all you need to do is stick with a basic dose, let's say 5,000, which is more than basic. That'll be a solid dose of the vitamin D3. Take that daily at the same time. The doctor would have already looked at, make sure that your liver's doing fine, because you don't want to give D3, unless you have a low level and your liver's doing well, at high levels. So in that situation, you will look at your vitamin D level. So what do you think the vitamin D level is in this area? You'd figure it'd be kind of low, right? Because of what I've been talking about. So the vitamin D level here, or the average, is somewhere between 17 and 20, 25, something like that. So maybe you could say the average is 20. And so then the question is, well, because we used to say, oh, well, it's not too, the person comes in with a D25 level of 30, 32 or something like that. Go, oh, it's not too bad. Maybe you need a little more. No, the guy's wrong. It's way low. It's still way low. What's normal is 80. And a lot of people don't really, it hasn't clicked in their head yet about that. So the range that I like to work with is 60 to 80. Because at 60, you're getting pretty much the benefit of an 80, all right? So this is the level of vitamin D, and that's a D25 test. So using that as a barometer, and you get your levels up, one of the first things we see with a D level that's come back up to normal is the person is feeling better and they have more energy, okay? And of course, vitamin D works to the level of the brain as well as the rest of the body, not just simply the bone, okay? So vitamin D is a key thing that is, it's only now that people are starting to pick up on this. We've known about this in the detail that I'm talking about since about 2014. You had a question?
Yeah, so you're saying we're running low in this area in particular. If you get enough, then can you start to, can you reverse, or is there?
Well, that's an interesting question. I think it depends on the status of your health. If let's say you have someone who is really in a poor health condition, they're older, they have less capability to recover, okay? Because remember, it's a hormone, so it doesn't work fast. The response to getting your levels up might take 6 months, okay? But I do think that in general, it does allow a lot of your systems to start working better, okay? The next talk I'll be giving is not the clinical side, but I'll be doing more of a biochemical side, focusing on mitochondria and things like that. But right now, what we're doing is clinical, and honest to goodness, cheapest stuff you can get is still good enough. It's amazing. And that would be, so as far as these other questions here, anybody have any questions about, let's say, the sleep issue? Because sleep is important. Any, I know I elaborated on that, but I want to make sure this point's taken home, because this is such a prevalent issue. Not to talk about it thoroughly is missing the point. Okay? Yes?
So, Joe, you said a sleep study can actually be done at home today.
Yeah. Mm-hmm.
Something you can order over the internet, do it yourself.
No, it's not that way.
Okay.
Here's how it happens. We have 3 or 4 sleep study centers in this area. They do a solid job, period. However, the insurance companies are saying no to that and just about everything else. So we had to figure out another system that works. And so we have a home sleep study where basically you have all the work is done with this belt that has all the electronics in it. And there's very small nasal cannula. I mean, instead of the size that you would have in the hospital, they may be the size of maybe the pen tip. It's that small. And you don't feel, it doesn't feel uncomfortable. And they give you a watch, and they tell you, go home and go to bed. And when you hook up, as soon as you hook up, that's when it starts. It picks up on everything. It doesn't give the detail. Remember, a full sleep study, a proper one is going to EEG and everything else. Okay? But it seems to be very accurate as far as ballpark. In other words, if it says you got a problem, you do have a problem. They don't go into super detail of it, but it's so we have a lot of the sleep doctors that are in charge of the sleep study, centers. They look at it and they say, "This is good enough. I don't have to do anything else," and they'll actually give the information there.
If it's positive.
Yes.
Yeah.
Yeah. Now let's say it was iffy, like if he hit, then and we always refer to them anyway, because we want to make sure that as someone who is a sleep specialist has looked at it and has made the right decision,
So you go to a sleep center, you get a belt, take it home, it monitors, it records, you take it back in, and they say, yep, you got a problem.
Yeah.
And then from there they can prescribe.
Yeah, they could. Yeah.
Okay.
Like we actually do it in our own office for the home ones. If the home ones are positive, we send them to the doctors who are specialists in that area. Yeah. So, but the reason why it's important is, think about it. If you had 43% of all the people who die in their sleep is from sleep apnea, and almost, I'd say 50% of all the American men who are overweight, mildly, like a BSA of like maybe 2.0 and higher, that group of people, they have a high degree of having sleep apnea. If they drink, it's very high. And most importantly, from my point of view, because I've seen this, is once they're treated, they have so much more energy and they have more zest for life. It's like all of a sudden it's like they went back 10 years in their brain. It's amazing. And the final aspect, which is really important, is the memory loss that they've had for the last 10 years or 5 years, whatever it is, it's reversible. And that's a big deal. The families notice it right away. Wives are very happy. They're very happy. It's straightforward. Okay. So I'm hammering this one down because it's important to know, because it affects so many people, and the consequences are very significant. The consequences of a low vitamin D level, well, it's there, but you have to kind of search through it because, it just means you're just getting older, right? Well, not necessarily that way, but that's kind of like what happens with the low vitamin D level. Okay.
Is the only way to check your vitamin D is through blood?
Yes. I mean, there may be another way, but the standard way, and it's covered. It's amazing. It's covered. That they would actually get the vitamin D level. And our typical vitamin D level, like I said, is around 20 for this area, because it's the sun. And one of the few times where you actually use your trigonometry and all that, the cosine level gives you an idea of, the power of the sun is related to the cosine, right? So that's how much you're going to have as far as stimulation to the bone and for the rest of the body for the ventral D level, okay? So, and one of the big questions about D is, isn't it going to get you toxic? Remember I said it in the beginning. So let's get back to that one question. The toxicity of D3 has a much greater range, so it's a higher threshold than the D2. So it makes it's really not. We haven't seen anybody toxic yet, okay? In fact, the toxicity is the toxicity we see that's more frequent is vitamin A. Vitamin A toxicity we see more often than vitamin D. But we were all taught vitamin D toxicity, be careful. It's like a hocus pocus thing, So, so those are two important issues there. I can take a look back at that, but here, any other questions in regards to some of the infectious issues? That's a broad area of infection, because infection could be Lyme's disease, but my goodness, it could be a standard infection, a wound. If there's enough, if it's infected enough, it puts a drain on the body because of the way the body's responding, etc. And of course, if you have infections, elderly people or people who are not able to be moved around, they get decubitus ulcers, things like that, which are not most people don't want to talk about it, but they're very serious. They have to be cleaned out, and it takes a lot of care for those people. So, any other questions? No? Okay, very good. Thank you for listening.